I'm good. Okay, great. So thank you, David, and thank you, everyone, for the opportunity to speak with you today about the N.W.T. Pandemic Response Plan. This has really been a truly collaborative effort and lots of work from lots of people to get this in place. So I'll go through a number of slides to talk you through the main components of the Pandemic Response Plan, and then I'd be happy to take questions at the end. So we all have a role to play in this pandemic, as you know. How much we demand of our healthcare system and what parts of the pandemic response plan we activate depend on everyone's behavior in the N.W.T. I'm just going to pause for a second and ask if people can mute if their lines are not muted, just so that we can all hopefully hear well. By following the orders of the Chief Public Health Officer to limit contact with others through physical distancing, we know that we can all help to lessen the impact of COVID-19 on individuals, communities, and our health and social services system. So this plan has been developed to be able to help our system respond to COVID-19 in whatever form it takes. But this is really important to know that the orders from the Chief Public Health Officer and how well we follow them really will really determine what kind of response we need to mount. The N.W.T. Pandemic Response Plan has been a really truly collaborative effort, as I mentioned, between the NTHSSA, the Clecho Community Services Agency, the Hay River Health and Social Services Authority, and the Department of Health and Social Services. You should have all received a copy of the plan as well as the summary document, which we'll publish to our public website after the briefing. The Pandemic Response Plan is really the how of the pandemic response. We have taken guidance and direction from the Office of the Chief Public Health Officer on the what, and made a detailed plan of how the operational arms of the health system will respond to the COVID-19 pandemic. There have been three key priorities of the planning approach: planning, caring, and protecting. Planning includes a detailed approach to preparing the health system to respond to the demands of the COVID-19 pandemic. Caring means ensuring that our staff have the information and support to provide high quality care to patients during the pandemic, both to those with COVID and also by ensuring that we continue to meet people's non-COVID healthcare needs. And third, protecting encompasses our activities to ensure that our staff are protected and safe. We're on slide 5 for anyone who might be following the deck, not on the screen. I'll just maybe mention the slide numbers as I go. The authority's COVID response team was struck in March, or the ACRT. The executive co-leads are the Territorial Medical Director, myself, and the Northwest Territories Health and Social Services Agency Authority Director of Health Services. Together, we lead a team with expertise in every area of the health system to ensure a coordinated COVID-19 response. We also liaise with the Department of Health and MACA through the EOC, or Emergency Operations Center. The 4 components shown here align with the 4 major areas of the pandemic plan released by the Department of Health and Social Services. The rest of the presentation will provide more detail on each of these areas. However, I will focus mostly on that bottom left quadrant of health services, while touching briefly on the other areas. The pandemic plan is really the detailed health services response. Next slide is slide 6. So this gives a bit of a basic graphic of what we are expecting and what our planning is based on. The assumption that approximately 80% of people who contract COVID-19 will have a mild symptoms or a mild illness. And this means that 80% of people who have the illness will be able to self-isolate and recover at home. We expect, based on epidemiological data from other jurisdictions, that 15% of people who contract COVID-19 will have moderate symptoms. And that means that those people are sick enough to require hospitalization and supportive care, but not critical care. 5% of people who contract COVID-19 will have severe symptoms, and those are the people that require critical care support, which may include intensive care unit, it may include ventilation or other more advanced forms of health services. Next slide is slide 7. It's important to prepare, of course, as a system to manage patients with COVID-19. But it's also important that we ensure that N.W.T. residents still have access to care and services, including primary and preventative care, chronic disease management, surgeries, and other procedures. Slide 8. Slide 8 talks about the health service planning for COVID-19 patients specifically. And then the following slide, I'll talk about how we are continuing to meet the needs of people for non-COVID issues. The health services response that is planned for COVID-19 patients ensures that care pathways are clear and consistent throughout the territory. Planning has included everything from how to care for patients with COVID, to testing strategies and implementation, to isolation planning, to surge planning, to ethical decision-making. We have educated our staff on Canadian guidelines for clinical management of patients with COVID-19, as well as on approaches to goals of care discussions, which I'll speak more to on slide 14. We have created pathways for patient assessment and management based on algorithms prepared by the Office of the Chief Public Health Officer. And of course, we have expanded our resources, including bed capacity, equipment, and staffing. We've also developed a framework on decision-making when resources are scarce, which I'll speak to shortly. We're on slide 9. It is important to note that one of the biggest threats of the pandemic may actually be the impact on non-COVID health issues due to tight resources or interruption of preventative care and chronic disease management. This has been a big focus for us. It is critical that we continue to provide health services during the pandemic to safeguard against this and to protect the health and wellness of our population. We know that physical distancing is a key public health measure to prevent viral spread. Yet the question has been, how do we reconcile that with the continuation of provision of necessary healthcare services? The answer has not been black and white, and it's a matter of balancing risks. With that in mind, we've asked our staff and patients to think differently about how care is provided and received. When appropriate, we have asked people to replace face-to-face encounters with virtual encounters. This means meeting the patient's healthcare needs by phone or video, and hopefully soon by secure messaging. However, on the flip side, we must continue face-to-face encounters when appropriate. For example, those that require physical exam or procedures. We have reduced patient movement by reducing unnecessary or inefficient in-person presentations to healthcare facilities as well. For example, many specialists are now doing virtual encounters to replace travel to Yellowknife. Or if travel is required for a procedure, then they meet the patient virtually in advance to make the time in Yellowknife as short and efficient as possible. Another example of this, of reducing unnecessary in-person presentation, is being able to fax lab requisitions directly from primary care clinics in Yellowknife to the lab, rather than having to pick up a piece of paper in person. We've also reminded people about the importance of the Choosing Wisely international campaign that predated COVID. The message from Choosing Wisely is don't do tests, assessments, or treatments for things that are not evidence-based or will not impact health outcomes. And this has been a really great opportunity for Choosing Wisely in terms of really focusing on the health services that really are evidence-based and make a difference to people. We need to stop doing the things that aren't necessary. Next slide is slide 10. I'll now move into some of the specifics of the pandemic response plan. This slide outlines the N.W.T. territorial pandemic stages, which have been aligned with Alberta's stages of surge during pandemic and disaster. The executive leads of the authority's COVID response team, again, the Territorial Medical Director and Director of Health Services, are responsible for activating each stage of the pandemic response plan. I'll just take a couple of minutes to go through each of these. So stage 1 is defined by the first COVID-19 hospitalization. That's the trigger. So we were in stage 1 a few months ago. In stage 1, the goal is to detect and contact trace initial isolated cases and prevent community transmission. And during stage 1, we have the capacity to have 72 beds in total at Stanton. And I'll talk a little bit in future slides about why we are focusing the surge capacity at Stanton. So in stage 1, we have 6 ICU beds, 36 beds that can be designated COVID positive, and 30 other beds. Stage 2 is considered moderate, and the trigger for that is community transmission. So when we start having spread of COVID-19 through the communities that is not related to travel. At this stage, our goal is to have all activities aimed to reduce the rate of infection in the territory, which is what we call flattening the curve. So we want to make sure that if COVID is spreading, that it's spreading slowly so that we don't surpass the capacity of the system. In stage 2, we can surge to 8 ICU beds, 49 COVID positive designated beds, and 17 other beds. Stage 3 is defined as major, And the trigger for that is when 50% of the designated COVID-19 inpatient beds at Stanton are full. At that stage, the goal is to maintain capacity at Stanton to delay or avoid progression to stage 4. At that point, we'll have 8 ICU beds, 63 COVID positive beds, and 17 other beds for a total of 88 beds. Stage 4, we hope we will never get to. This is a critical stage when we have to start making decisions about scarce resources. At that point, some or all of our critical system resources exceed maximum capacity. The goal at that stage is to use all available resources and external agency supports and relationships to return to territorial response stage 3. At that stage, we'll have 8 ICU beds. All of the other beds will be designated COVID positive for a total of 92 beds, which includes 4 emergency department beds. One of the questions I often get is, how are we actually expanding the number of beds? And the answer is by opening currently unopened beds at Stanton and repurposing some outpatient beds, such as day procedures. A few months ago, we were in stage 1 with the first hospital admission, though arguably one might say we're back in stage 0 right now because we have no active cases. Regardless, the current goal remains the same as it was in stage 1, to detect and contact trace those initial isolated cases, prevent community transmission by promoting public health measures from the Office of the Chief Public Health Officer, reduce in-person health encounters by replacing with virtual care where appropriate, and maintain evidence-based health activities. One very important thing to understand in our response planning is that it depends strongly on our relationship with Alberta. As we always have, we will rely on this partnership to provide specific services that we don't provide in the N.W.T. This means that some patients who have very specific care requirements will be transported to Alberta, even if we still have capacity in our system. Alberta has assured us that they will continue to provide this support to our patients. An example of this is something called ECMO, or it's a type of life support, which is an advanced technique of providing prolonged heart and lung support to people who are critically ill. This is something we don't provide in the N.W.T. And if a patient was sick enough to need this, they would be transported to Alberta, regardless of our number of available beds. We would also, of course, rely on this partnership with Alberta if we did, in fact, exhaust resources in our system, such as ICU beds. If stage 4 were ever to be activated, the scarce resource triage approach will be utilized, both for internal decision-making and for communication with Alberta regarding support and transfer. I'll speak more to this on slide 17. Slide 11 shows response stages along the curve, and that concept we've talked about a lot of flattening the curve. It gives a simplified visual presentation of the different scenarios that may arise. So you can see in red the very high steep peak that could occur if we didn't have any protective measures in place. So that means if the Chief Public Health Officer was not asking us to physically distance and didn't have border controls in place, if we didn't have any of the protective measures, it's very likely that we could have a very fast high peak of COVID cases. With protective measures in place, we hope to see something more like the blue curve, which is a slower peak and a lower peak. And you can see that with a dotted line, the healthcare system capacity. We hope to not exceed the capacity of our system by keeping that curve low and flat. And again, that's really going to depend on the behavior of everyone in the N.W.T. and how well they're following the advice of Dr. Candola. So we're on slide 12 now, and the next 2 slides show you a simplified version of the planned patient flow. First, I'll talk about mild symptoms, and then I'll talk about moderate to severe symptoms. So when a patient presents with mild symptoms, so those are the 80% of cases, this could be anywhere in the territory. First, a swab is collected, and then the question is asked, can the patient safely self-isolate at home? In most cases, yes, they may be able to, in which case they're going to be given instructions to self-isolate, and they'll receive support via virtual care checks to make sure that they're recovering and not worsening. If the COVID-19 test result comes back negative, then they'll be given instructions on when they can complete their self-isolation, depending on how their symptoms are going. If the COVID-19 test result comes back positive, they'll be monitored and supported until 2 negative tests come back 24 hours apart. If you go back in the algorithm again to can the patient safely self-isolate at home, if they are unable to do this, then we need to support that person in being able to safely self-isolate, which may require transportation to an isolation center. And this is where the collaboration with MACA and communities comes into play with the setup of isolation centers. Slide 13. This talks about moderate to severe symptoms. And before I go through this flow, I'm going to stop for just a second to speak briefly about a concept called goals of care, as this is a very important consideration in providing patient-partnered and respectful health services. Goals of care have to do with health care during a significant illness and at the end of life. It's very important that people have very clear discussions with their families and healthcare providers about their values and directions they would like to give regarding their care in the event of a significant illness. This applies to any illness, not just COVID-19. Healthcare providers must work with patients and their families to identify these values and their cultural beliefs around end-of-life care and ensure that they align with the patient's goals of care. This is particularly important for patients who are elderly, frail, or even or who have significant medical issues that would predict a poor outcome in the event of a severe COVID-19 infection. For example, some patients may choose not to be put on a ventilator or even not to be transported out of their community. Some may choose comfort care or what we would call palliative care only. So going back to this slide with the patient flow, you can see that that first box is exactly that, goals of care. So the first question, when someone presents with severe symptoms requiring urgent care, potentially transport, the question is, what are their values? Do they want to receive active treatment or comfort care? If they choose to receive comfort care, we will try to provide care and support as close to home as possible. If the person chooses active treatment, transportation will be to Stanton Hospital during most of the stages of the pandemic response. The reason for this is because Stanton is where we have the capacity to surge, but it's also where we have the equipment and personnel and skills to be able to take care of people who are this sick. We simply don't have the equipment and expertise in many of the communities to be able to care for people who are moderately or severely sick with COVID-19. In stage 3, when we're getting to a point of having many inpatients at Stanton and we are looking at bed capacity issues, it is possible that patients who are COVID positive at that stage could also be admitted to a Nunavut Regional Hospital. Those would be moderately unwell patients, not severely unwell. Again, if you're severely unwell in that 5% requiring intensive care unit support, that can only be done at Stanton. Appropriate in-hospital care would then be provided and monitoring and supporting until self-isolation is discontinued by a healthcare provider. The next slide is slide 14. I'd like to take this opportunity to answer what many people want to know. What happens if demand exceeds the supply of resources, including hospital beds or ventilators or staff? This is a challenging area that every health system has had to and is grappling with. The NTHSSA has developed a scarce resources approach to use ethical principles in allocating limited resources should the need ever arise. Limited resources could include limited available medevacs, ventilators, critical care beds, or staff. In response to Alberta's request to align with them, we used a document called the Alberta Health Services Critical Care Triage during pandemic or disaster to develop our own process for critical resource triage in the N.W.T. This document was used in conjunction with the already existing NTHSSA ethical decision-making framework to use ethical principles for determination of scarce resource allocation. Again, our strong relationship with Alberta is key in our planned COVID-19 pandemic response. So far, Alberta fortunately has not come close to reaching their hospital or ICU capacity. The scarce resource approach has allowed us to plan for worst case scenarios, though we hope never to be in a situation of severe scarcity because of the strong partnership with Alberta. Slide 15. I'll move now into describing two critical components of surveillance in a pandemic, testing and contact tracing. Early on, we established testing availability in all communities. However, one of our greatest challenges has been our reliance on sending tests out to Alberta, resulting in a long turnaround time. On average, 4 to 6 days. The most recent statistic was 5.8 days, but sometimes much longer. This turnaround time is really not ideal for effectively managing a pandemic. We need to be able to rapidly detect, contain, and contact trace positive cases, which is why rapid testing capacity has been a pillar of the Chief Public Health Officer's plan. We do, of course, have some rapid testing capacity in the form of the Gene Expert, now both at Stanton and in Inuvik, as well as the recently acquired BioFire. However, worldwide shortages of the consumables, the materials required to run the tests, have meant that we can only use these rapid testing devices in certain situations. Fortunately, there has been great progress in this in the last few weeks, and right now we're very close to announcing further advancements in our rapid testing capacity. We expect to make an announcement about this in the coming week or two with details on how we will be improving testing and turnaround time by providing more rapid testing on the ground in the N.W.T. We expect that testing demand is going to increase in the coming weeks through a combination of entering the season for respiratory infections, as well as return to school and workplaces that will not allow symptomatic students or workers into facilities. Contact tracing, of course, is very critical to the pandemic response as well. We've established processes and protocols for rapid contact tracing of positive cases. This is really important so that we can contact these people and make sure that they're on self-isolation as fast as possible. We also have processes in place to support COVID suspect patients to make sure they appropriately self-isolate to prevent spread. Immunization programs. There's a lot of work underway establishing options for both site and mass-specific immunization programs, specifically for influenza. We are anticipating a significantly higher uptake of the flu vaccine this year, as other jurisdictions have seen, actually across the entire world. And we hope that this will be the case in the N.W.T. too, that people will come out to get their influenza vaccine. A vaccine for influenza will not protect against COVID-19, and a vaccine for COVID-19 will not protect against influenza. And one of the things that public health experts are really worried about right now is what they're calling a twindemic, or having both really high numbers of COVID-19 and high numbers of influenza, which would be very, very dangerous for all of our patients and, of course, also for our health system. We've ordered supplies and are designing novel ways to reach everyone who wants to have an influenza vaccine without the traditional model of lining up in public spaces. And of course, this will be a great dry run as well for preparation for when the COVID-19 vaccine is available. Slide 16, IPAC and OHS. So IPAC stands for Infection Prevention and Control, and OHS is Occupational Health and Safety. So these are two very, very important areas for protection of both our workforce and our patients. One of the big announcements that was made this week was about continuous masking. And so I'll just touch on that. Starting on Monday, August 31st, the N.W.T. Health and Social Services Authorities started the process of implementing continuous masking in all facilities across the N.W.T. And we hope that this will be, the process will be finalized and in place by September 14th. This means that all employees that can't maintain that 2-meter distance from other individuals will be required to wear either a cloth or a non-medical mask or a medical mask, depending on the nature of their work and the location of their work site and space. It also means that we'll be asking the public coming into our facilities to wear masks. One of the questions has been, why now? When we don't have any new cases, why are we deciding to do this right now? Well, it's because there is an increased risk right now. COVID-19, of course, is still present in Canada. There still is the risk of asymptomatic spread. And we do worry about the increased recent movement, recent travel into the N.W.T, and also increased contact because of return to school and return to workplaces. So we know that because people are going to be in smaller spaces together with more contact, there is a higher risk of spreading the virus, whether it's COVID-19 or whether it's another respiratory virus. And because there is a delay in actually detecting the COVID virus, and because there is a risk of asymptomatic spread, we really thought that it was time to actually implement continuous masking to protect both our staff and our patients. We also, of course, have had the benefit of time in being able to procure more PPE and more masks to be able to do this safely. So in closing, I'd like to just acknowledge that while COVID-19 has presented us with a really unprecedented challenge, it has also come with a silver lining. It's given us insight into what we can accomplish together. In the N.W.T, we are small, and that comes with great challenges, but we are strong and we know now how effectively we can work together. The hardest is really yet to come for all of us in the N.W.T. with COVID-19. But we know that we can do this, that we can rely on each other to safeguard the health and wellness of N.W.T. residents. I'll finish the presentation there and switch back over here to video, and I'm happy to take any questions that you may have.
Okay, so Sarah, I'm just going to dive in here so we can manage this in an organized way. I actually have a list of everybody on the call in the right-hand column, and I have them all just for call quality here. So Sarah, I think your screen's still sharing, or else there's a bit of a delay there. But if you just want to hit stop sharing, that'll give us better video here for question period. So I'm going to start. We'll do one question, one follow-up each, and I'll just work through the list as it is on the right here. And I'm going to start with Mario from CBC Radio Canada.
Hi, good morning, everybody. I guess a question, you kind of answered that, and you kind of answered it just now talking about the necessity of having the mask, but can you speak a bit more about the necessity of making this plan now? Of course, there are a lot of questions like, you know, this has been happening for quite some time now. So how, I guess that's my first question, just why was it so important for today, you know, months after to have this new updated plan announced today?
Thanks for the question. It's really been a matter of balancing risks. And initially, at the beginning, when we were looking at mask wearing and the evidence and the timing and the PPE supplies, it was really a matter of trying to figure out the timing of when the risks were high enough that it justified going to continuous masking and the increased what we call burn rate of going through masks. So when we are talking about continuous masking in health facilities, for people who are actually in contact with patients, we have to use medical masks or disposable masks, not cloth masks. Cloth masks provide some protection for the patient, but they don't provide a lot of protection for the wearer. There's also, of course, variable quality with cloth masks. And so we really can't suggest to our staff that they need to wear cloth masks when in contact with patients as a form of protection, because that's not evidence-based. So as you know, we're in a global pandemic, and there's a shortage of all consumables that are related to this pandemic, including personal protective equipment and masks, surgical masks. And so going to the decision of continuous masking in health facilities that requires the use of medical masks meant really being careful about the calculation of that burn rate and how many masks we'd be going through on a daily basis, and making sure that we had enough to be able to keep our staff and patients safe for the duration of the pandemic. So that was one aspect of the risk analysis. Another aspect of the risk analysis was really about the COVID activity. And so the thing that has led us to make this decision now, in addition to the PPE supply, is also about the increased risk that I had mentioned, that because we now have people back in school and also back in workplaces, and because we're approaching the season of increased respiratory illnesses, we know that there's an increased risk of transmission of viral illness, including COVID-19. So it's really because of that increased risk now that the timing of the decision has been made.
And I guess for my follow-up, more about the response plan itself, like, can you give us an idea of what, like, we're talking about it today, but how does that change from what we were doing, you know, two weeks ago, the things that really changed?
Thank you.
The plan itself, not the masks.
I see. Yes. No, that's a great question of why now. So this pandemic plan was developed actually quite early on in the pandemic response, and was shared with staff. So the staff have been aware of this and using the algorithms and information in it. There was various kind of engagement that needed to occur with various stakeholders. And so it's being presented publicly now, but it's not because that there's been any kind of recent specific change in the overall pandemic plan, but rather that it took time to kind of roll it out to staff and to make sure that everybody was familiar with it. This document is really, we're sharing it for awareness publicly, but it's really a document, as you would have seen, that is designed for giving instruction to people within our system operationally.
Oh, sorry. John last. That was my fault. I was on mute. I have a lot of mutes going here. John, you're up next. Sorry about that. Go ahead. Okay, one more chance for John last.
Maybe he's on mute.
No, well, he might be on mute. Are you on mute on your end, John? Can you just double check? I'm gonna pass you after this one to the next down. Oh, John's on the phone. Okay. Can we hear you now, John? Okay,
Yeah,
sorry.
can you hear me?
There's two in here twice. Sorry, I'll note that for next time. Go ahead.
Okay, I just had a couple of questions here. So the first one is, I noticed that this plan doesn't include any mention of the coordinated secretariat that was announced yesterday. Can you explain why that's not included here?
Thanks for the question, John. So, this is again the health authority's operational response plan. So this is really the details of how we care for patients, make decisions around patient movement, how do we deal with scarce resources. So it's very much an operational document, and it actually long predated the announcement of the COVID secretariat. We're very excited to work collaboratively with this new secretariat, and I think it will be great to see how the secretariat is able to improve the efficiency of how various departments work together. And they'll be looking at broader issues in terms of the isolation, how communities are preparing, all of the kind of broader preparedness and response items. But this document's really about the health services response, not the entire government pandemic response. So that's why there's no mention of it in here, is that it's really confined to the operational health services part.
Okay, but you expect to be working with the secretariat as part of this plan?
That's right.
Okay, and the other thing I wanted to ask is just what the 80% mild symptoms is based on. I looked into where those numbers might be coming from, and it looks like there's a study from back in March, a large-scale study that's kind of been the basis of that claim elsewhere, but I'm just wondering what that where that's coming from.
Yeah, so I can't quote the exact study, but it's the basis of the planning that's been used in a lot of jurisdictions. And I think as we go through this pandemic, of course, we are learning daily and weekly more about the virus itself, about how it behaves. Our understanding of it now is certainly quite different than it was at the beginning, including how it affects children, how it's transmitted, even how we treat it. So, that is it's a rough estimate based on evidence that came out early on in the pandemic, and it's how jurisdictions are planning. It's certainly not exact, and it may not be that it's exact in our jurisdiction. We have a young population in the N.W.T, but we also have a high burden of chronic disease. And so, it is possible that it won't be exactly the 80%, 15%, 5%, but we had to make plan our response based on some assumptions, and that was the best that we had at the time. But of course, we will be responding to individual patient needs as they rise. And so whether or not it turns out that the epidemiology matches that in the N.W.T or not, it doesn't really matter, because a response plan is such that we will respond to everyone's individual need based on what it is that they present with.
Sorry, I keep forgetting to mute myself. I'll mute myself, everybody. Thank you, John. We're going to move on to Blair McBride, and we'll come back through everybody one more time afterwards. So Blair, go ahead. One question, one follow-up.
Yes, can you hear me?
Yes.
Yes, hello. Yeah, so my question is, in case there is a widespread outbreak or even a moderate level outbreak, and a lot more resources are being used up at Stanton and other health centers, what will be the plan for things like surgeries here, dealing with issues like cancer patients, other serious health conditions that aren't necessarily immediately life-threatening?
Mm-hmm. That's a great question. And Blair, there was one word I missed there. I heard you say surgeries and I missed the second word there.
I think I just said like dealing with other serious health issues that aren't necessarily immediately life-threatening.
Yes. Yeah, that's a great question. So again, this is, it needs to be a balance in our health system's response of meeting the needs, of course, of COVID patients, but also making sure that we're meeting the needs of everything that's non-COVID related as well. And so, if we have an increased number or a surge of COVID-19 cases again, it will be a situation where we would have to ramp down non-urgent care as we did initially. So at the beginning of the pandemic, when we didn't know what to expect, we did, as you may recall, ramp down and stop doing particularly elective surgeries. And that was because initially we needed to have time to actually plan. How are we going to respond to this? What are our PPE protocols? What are our OR protocols? How are we going to triage these cases? And so it would be a similar situation that if we were getting to a point of surpassing our capacity, we would need to proactively start to ramp down some of those non-urgent services. Urgent healthcare services will always be provided, whether it's COVID or not. And the triaging of patients, of how we determine who needs what healthcare, it's not based on whether they have COVID or not. It's based on how sick they are, whether it's from COVID or from a heart attack or anything else. So that kind of urgent care will always be provided, and always, of course, in conjunction with our partners in Alberta, as it always has been. But for those kind of less emergent or less urgent issues, it really is going to be a matter of balancing our capacity and also trying not to increase wait times and making sure that we're still meeting people's needs. The other thing to note is that with primary and preventative care, so going into a clinic to see your family doctor, nurse practitioner, or community health nurse in communities, that we want to continue wherever possible throughout the pandemic. And if it means switching more to virtual when we have more cases, then we'll do that, as we did initially as well. And we really did ramp up our virtual care capacity to be able to do that, because the burden of disease could be significant if we went for a long period of time without caring for people with chronic diseases, for example.
Follow up, Blair?
Yes. And what about, I'm not sure how related this is, but like, how would dental care be affected by this if a lot more medical resources are being tied up at the major health centers?
That's a great question. So generally, dental care doesn't fall under the health authority, although some dental care is provided in some community health centers through a bit of a kind of a legacy arrangement. That's not the case in the larger communities. So, it is a concern, because oral health is very important to overall health, the same way that, primary and preventative care is really important to overall health. And so it is important that dental care continue where possible. But the decisions around what dentists are allowed to do and what the restrictions are has actually been a discussion between the dentists and the Office of the Chief Public Health Officer, not with the health authority. So I can't answer any specifics on that. But if you did want to ask specifics about how that will be managed, it's a question for the OCPHO.
Okay, thanks.
Okay, thanks. I'm going to move on to Emily Blake from Cabin Radio.
Hi, my question is in terms of, community health centers. A lot of communities are raising concerns that they want, more healthcare staff there. What's the status of that, and is that something that is being considered?
So more healthcare staff in terms of the response to the pandemic, or are you speaking more broadly about the kind of broader issues of equity and access to healthcare providers?
Yeah, more of the broader concerns, which I think have those concerns have just sort of escalated during the pandemic.
Yeah, no, it's a good question, and it's a big challenge in the N.W.T, of course, with our vast geography, and how do you provide equitable access to healthcare services when we're spread over such a big area, and when we can't have all expertise in every area. So, I think part of the answer to that is that with the creation of a single health authority, working closely together with Hay River and TCSA, over the last few years, we've been working really carefully and closely together to look at how we actually will address that. And one of the ways that we've been looking at that is how do we create teams that can work together in multidisciplinary ways virtually. And so the pandemic has actually created a great opportunity to advance virtual care to enable people throughout the territory to access services that are not in their own community and that they may not have before. So a good example would be rehab services. So occupational therapy, physiotherapy, speech language pathology. They had great success with the advances in virtual care to be able to provide virtual care and appointments to their patients in their homes. And so it wouldn't matter what community they're in. And it was interesting that one of the benefits that they saw was in kind of one that they didn't expect, which is that they were able to actually assess people in their own home environment, so that if they were giving physio exercises, for example, or they were assessing their safety at home from an occupational therapy perspective, they were able to actually see it in the context of the person's home, which added great value to their assessments. So I think in general, and also during the pandemic, this has been a really great opportunity to look at how we increase equity and access to multidisciplinary healthcare providers throughout the territory. And I hope that we will certainly be able to continue to advance that even after the pandemic as well.
And I guess, with the internet access not being equitable across the territory, has that been an added challenge with the virtual care?
Absolutely. That is definitely a challenge. And it is something, of course, that's not within the control or domain of the health authority, but something I would certainly advocate for in terms of the importance of equity and access to care. Having adequate internet is foundational to that. And so, yes, that has been a challenge because there are some communities that do have challenges with internet. So one of the ways that we've tried to address that, and this predates the pandemic as well, is having dedicated bandwidth for telehealth. So telehealth units where people can go into a health center and then connect with a healthcare provider in another community. So there's dedicated bandwidth for that. But one of the things that we've tried to do with the pandemic is really open up virtual care so that people can use their handheld devices if they have them, to be able to access their healthcare providers directly that way. And absolutely, internet is an issue in communities and makes it not possible for some to be able to do that.
Okay, thanks, Emily. I'm going to move on to John Van Dusen at CBC, and then we'll start from the top of the list for one more round for everybody else.
Hi, thanks, Dr. Cook. This is a question about the response plan. It mentioned that self-isolation facilities are being identified in several communities to support those who can't self-isolate at home while they recover. And I was just wondering if you could provide an update on that and maybe explain how these places are identified.
Great question, John. And this is something that's actually under MACA. So we are working closely together with MACA through the Emergency Operations Center. But the designation of the isolation facilities and working together with communities is really under their domain. So I would suggest to get an update that's accurate, I would suggest following up with MACA. Unless there's Tim or anyone else on the line wants to jump in to give an update on that.
Sir, it's Tim Van Overloo here. That's a perfect update. I think we've collaborated with the regional emergency management operations to provide information around what would be required in self-isolation, and they're actively looking at identifying spaces and or informing us where we'll have to move patients if it gets to that need.
Thanks, Tim.
So, John, go ahead with the follow-up if you've got one there.
Sure. The plan mentioned that the ability for the health system to scale response is constrained by a few things. It mentioned a lack of healthcare providers, equipment challenges, and transportation needs. And I'm just wondering if you could talk about some of those challenges and maybe what is, you think, the most pressing one of those three moving forward?
Great question. So those are we could potentially be constrained in all of those areas or any one of those areas. So if I think, for example, to give the example of transportation and medevacs, there are only so many medevac planes and only so many medevac teams that can be in the air at any one time. And so, it is definitely possible to exceed the capacity if we have a number of patients throughout the territory that need to be moved at a particular time who are critically unwell. And so that could put us in a very difficult position of having to use that scarce resource triage framework to be able to try to make decisions. And I think we would do everything in our capacity to try to avoid having to make those scarce resource decisions. But that would be an example. Bed capacity, it really depends on how this plays out again. And if you recall the slide I showed with the steep curve versus the low curve, that really speaks to the difference in what we'll be looking at depending on how people behave and really how well people follow the orders of the Chief Public Health Officer. So, with bed capacity or staff capacity, or even the medevac capacity, transport capacity, it really does depend on that. So if we have a slow rise of the curve, we hope to not exceed that capacity. Whereas if people are not physically distancing, if we have COVID cases and it rapidly spreads and people rapidly get sick and we have lots of people are critically ill, then we could surpass any of those resources. One of the other challenges with staff, of course, is looking at staff being sick. And so as a small jurisdiction with a small number of healthcare providers, when we're comparing ourselves to provinces, there could be a significant impact if our healthcare providers became sick. So this is another really, really important part of the occupational health and safety part of our response plan, is keeping our staff safe and making sure that they have adequate personal protective equipment and supporting them to stay home if they're sick, trying not to bring people into the healthcare facilities if they're having symptoms. But that would be another challenge, is if we had a lot of staff that had COVID-19 at the same time, we'd be relying on trying to bring in locums or transporting more patients out if we got into that kind of situation. David, I don't know if you're on mute again.
Yeah. Oh, man. First time. Sorry, everybody. Mario, go ahead with you. We'll work through the list one more time. We'll start with Mario.
Yeah, I guess to maybe follow up somewhat on what John was just asking there. This plan is based on resources available, on the capacity in the territory. Is there something missing? Is there something that you are actively chasing or asking for, whether it be to the territorial government, to the federal, to anybody?
We are actively pursuing everything, actually. So whether it's PPE or testing supplies or staff, we are pursuing everything. And I think everyone is actually who's involved in this pandemic. And because of that, everything is in short supply, including people. So yes. So to give an example, ventilators. So that's a common question, is how many ventilators do we have? Well, we have 3 more ventilators that have been on order for quite some time. They're scheduled to still arrive, but we don't have a date. So that would be an example of where early on we made a plan to procure more equipment, but because everyone is competing for the same resources, it's challenging. That's also why we're in the situation that we're in with the Gene Expert and BioFire, where we have limited consumables for those devices. And the same with the personal protective equipment. We have a whole team that works on this every single day, trying to advocate for getting more PPE. So absolutely, I would say that there's probably no domain where we're not working on trying to get more.
I'm good. No follow-up. Thank you very much, Dr. Cook.
Thanks.
John last for second round.
Sure, yeah. So I just wanted to ask about the ethical framework. I noted that there's not an explicit discussion of systemic racism, which has been raised in the context of health decisions in the past. And looking at the questions that are included in that framework, a lot of them are kind of sort of more vague and bureaucratic than they are focused on kind of directly impacting patients. Can you speak a little bit about how that framework will address the issue of systemic racism and prevent, as it says in there, unchecked biases in the system?
That's a great question. And I think, part of the approach to avoiding that type of systemic racism is actually having a framework like this in place that guides people through ethical principles to make decisions so that they're not acting on those unconscious biases. So in the process of going through scarce resource decision-making, the healthcare provider team will consult with the Scarce Resource Triage Committee. That Scarce Resource Triage Committee has an Indigenous elder on it, also an ethicist from Alberta who's on contract with us, as well as healthcare providers. And so that team is there to actually support the healthcare providers that are actually providing care to the patient and trying to make the decision and guiding them through the ethical principles that are outlined in that document to try to make sure that the decision is sound and is not based on those unconscious biases or systemic racism. I thank you for the question, though, because it's very, very important that we address that in a really, certainly a challenging area.
And just to follow up, in that same section of the report, it says that the forms will be filled out by health workers and then submitted to the director of quality risk and client experience. What happens to the forms after that? Are they reevaluated? Are they kind of like, where do they go in the system?
When I think that you're talking about in the process when the form is submitted to the director who then convenes the Scarce Resource Triage Committee. So that's the committee that I was just speaking to that has the representation, Indigenous elder, ethicist, healthcare providers. So once they go through the decision-making, the document itself, it's actually a good question where it's actually stored. I'm not sure if that's your question. I would have to look into that to see afterwards where the actual decision-making, I would think that it would be stored in the patient chart, just like any patient documentation would be. I'm not sure if I'm getting at your question, though. Are you wondering whether there are other people?
No, it's good to know that the Scarce Resources Committee is kind of the next step after the form's filled out. Is there an appeals process that's kind of built into this whole framework?
That is also a good question that I don't have the immediate answer to, John. I would have to discuss that with the director of quality risk to see whether there is an appeal process. It is also a good question, though, because this, of course, is a really controversial topic and it is everywhere. And so we've aligned with Alberta's process, and I can't even speak off the top of my head to whether Alberta has an appeals process. I would have to look at their document as well. But our document and our process mirrors theirs exactly, which was their request to make sure that when we are making decisions together and making decisions with transporting patients between N.W.T and Alberta, that we're kind of using the same language and same ethical principles and same stages of the pandemic. So it's a good question that we can get back to you on about the appeals.
Okay, Blair McBride. Blair? Okay, I'll move on to Emily Blake then.
I think that covered all of the questions that I had.
Yeah, it is.
Okay, John Van Dusen at CBC, and I'll give Blair one more chance after this, and then we'll close it off.
I had a question just around the patient flow. One of the things that was mentioned that some patients with mild symptoms will be assessed and swabbed by a healthcare provider in person or virtually. And I just had a question about the virtual part of that. Would that mean someone at home would have to sort of swab themselves? And if so, how would that work? And how will you guys ensure that you're going to get an accurate sample?
So no. I also clarify that. So no, the initial assessment is definitely in person. So the swab would be done by a healthcare provider in person. Sorry, the virtual part of that is the assessment after the person is swabbed. So once they are self-isolated and awaiting their swab results, there can be virtual assessments done by a healthcare provider to make sure that they're okay, to make sure that their symptoms aren't worsening. And same thing after a result comes back positive. So we know someone is COVID-19 positive, but their symptoms are mild, they're safe to stay at home. The follow-up would be virtually. If there are any concerns that the person was having declining symptoms or was needing to have a physical exam, then that would occur in person by the healthcare provider. Depending on the community, it could be a home visit or it could be a visit into the healthcare facility, depending again on staffing and on the community. But no, the first assessment and the swab is done in person.
Okay, thanks for clarifying that. I guess just sort of a last question I would ask you is sort of big picture and moving forward. You talked a little bit about maybe some of the lasting legacies of this pandemic on the healthcare system here, about not doing things or stop doing things that aren't necessary moving forward. Just wondering, what other lasting legacies do you think, or lessons learned, the territory can use moving forward from this?
Thank you. I think that there is a huge opportunity with this pandemic to learn lessons that will improve the way that we function together moving forward. So one is how we work together, actually. And I think that it's been quite unprecedented in the pandemic, seeing how the health authorities have worked together with the Department of Health, with MACA, to really make sure that we can come together to create a plan that's effective. And we did that very rapidly, and we continue to meet on a regular basis. Virtual care is a huge opportunity that I've spoken to a fair number of times in this hour, but I'll just touch on again. It's something that we have been talking about for a long time, again, much before the pandemic. The opportunity to reduce unnecessary patient movement in this territory is significant. We have a long history of moving people as the form of health information. So we move people from small communities to Yellowknife, from Yellowknife to Edmonton, Edmonton back to small communities. And we do that at great inconvenience to patients and great cost. And often it's not necessary. So we've all heard those stories of people who fly down to Edmonton, see a doctor for 30 seconds, there's no laying on of hands, fly all the way back, and it can be 5 days from the time they left their community. That can have really big impacts on patients and their families at home and their work. And so I think that this has provided a really great opportunity to really move forward and looking at that and how do we reduce unnecessary patient movement. Of course, during COVID, we have to do that because we don't want people to be exposed to the virus and then bring it back into the territory. But it's something we need to do anyway to provide appropriate care close to home. So I think that that's something I hope will be a lasting legacy of this, is that we will really understand how we can do that effectively using virtual care, using virtual integrated interdisciplinary care teams, which includes a kind of a circle of care with our Edmonton specialists as well, so that we're all working together. We do have Edmonton specialists now who have licenses for virtual care in the N.W.T. That's been another advancement during the pandemic. So a lot of those in-person visits that were required before are now being done virtually from those specialists. So that's been really significant. And then again, you mentioned the unnecessary care. So the choosing wisely part, I think, is a really big opportunity as well. So really thinking about what is it that really makes a difference in terms of people's health and wellness. What is it in our healthcare system that actually helps people? And what is it that is either low value or potentially harms people? Because we know that there's a lot of unnecessary care that happens in healthcare that can actually cause harm. And so I think this has been a really great opportunity to take a look at that. And I hope that that will be a lasting legacy as well.
Okay, Blair McBride's back in the chat here. So we're going to give him the last question and follow up. And then after that, anybody who has further questions can shoot me an email and we'll sort them out that way.
Yes. Right. So you mentioned earlier that you expect a big announcement in the next, I believe you said the next week, about rapid testing capacity. Is it possible that one benefit of this I mean, I don't know obviously what the announcement will be yet, but one possible benefit will be that self-isolation time could be reduced from 2 weeks to less than that for people, residents or visitors entering the territory.
Great question. And this is actually a question for the Chief Public Health Officer, because although we are the ones who operationalize the testing strategy, she's the one in her office that actually sets the strategy. So the question of whether the advances in our ability to rapidly test will change isolation requirements is something that's being actively looked at by her office, but she's the one who's going to make that ultimate decision based on the evidence. There remains, of course, the risk that we always talk about of false negatives, particularly with people that have the virus but don't have symptoms. So it's always going to be a weighing of risks of the impact of isolation times, which we know have a really big impact on people and our society. Weighing that with the risks of potentially having false negative results, where either you have symptoms and you can still get a false negative, or you don't have symptoms and even higher risk of a false negative. So it's not an easy thing for our chief public health officers across the country to kind of weigh the evidence on this and to make those decisions and recommendations. So I know that she's looking at that actively, and I'm sure that she will speak to that in the coming weeks as well.
Follow up, Blair?
No follow up.
Okay, that's it for today. I want to thank everybody for attending. And like I said, you all have my email. Get back to me via email if you have any follow-up questions, and we'll sort them out through the regular process. Have a good day, everybody.
Bye. Thank you.